Thank you everyone for joining us this evening. Welcome to tonight's PEP Talk, Thrombophilia Testing on Blood Thinners. Before we get started, we all wanted to acknowledge that today is Veterans Day, and we want to say thank you to all the veterans out there who have dedicated their lives to keeping all of us safe, and to say thank you for all of our current military members as well. Todd and I were discussing this before we went live tonight, and we just wanted to extend our thanks to all of you. With that, I'm going to introduce our clinical guest who is back by popular demand. And I think all three of us are in cold locations today, but we are joined tonight with Dr. Dana Angelini, who is from the Cleveland Clinic. She is an assistant professor of medicine there, and she is a hematologist oncologist at the Cleveland Clinic as well. She specializes in venous thromboembolism, hence your being here, prevention and treatment, anticoagulation decision-making, and patient-centered thrombosis care. Dr. Angelini completed her MD at Wright State University, her residency at the University Hospitals of Cleveland, and a fellowship in hematology and oncology at the University of Michigan. She is a board-certified in hematology, I can speak tonight, and medical oncology, and serves as our co-chair of the National Blood Clot Alliance Council of Emerging Researchers in Thrombosis, called CERT, which advances collaboration between early career clinicians, researchers, and patients in the thrombosis field. Dana, we are delighted to have you here with us again tonight on this incredibly important topic, particularly with your expertise in both thrombophilia and in anticoagulation. Okay, so before we get going, we do want to remind everyone that we are not here to give individual medical advice. Tonight's PEP Talk is for educational purposes only, so we ask that you please consult directly with your own doctor, as each person's situation is unique, but we're hoping that we're giving you information that you can use in that conversation with your clinician. And with that, I'm going to turn it over to my PEP partner, Todd Robertson, say that 3 times fast, to lead us through some polling questions.
Thank you very much, and I second what you said. To all the veterans out there, you are appreciated. So happy Veterans Day. And I will apologize, folks, in advance. I do have a little bit of a cold, so if you see me pop off my video, it's probably because I have to blow my nose, but we won't go into graphic details, but that's what's going on. We do have some polling questions to read for you. Those are going to be popping up on your screen. Here they go. I'm going to read them to you. If you could answer them, please do so, and we will review the results. We're going to have some poll questions at the very end as well. So before today, how confident are you in understanding when thrombophilia testing is appropriate? Very confident, somewhat confident, not very confident, not confident at all. Our second question, have you ever been tested or told you should be tested for an inherited thrombophilia? Yes, I've been tested. Yes, I've been told I should be tested. No, and I'm not sure. And our final question, what is your biggest concern when thinking about thrombophilia testing? Finding a genetic cause, fear of missing something important, cost, insurance issues, impact on family, children and relatives, and not sure what it means, a little bit of confusion. If you could answer those 3 questions, we'll let the answers pop up, and we'll review those real quick before I kick it back to Leslie. Always a very big topic, Leslie, in the support group. We talk about it every day.
Absolutely.
So I'm sure glad we're going to get some more answers today. So here's the results. Before today, how confident are you in understanding when thrombophilia testing is appropriate? Very confident, only 6%. Somewhat confident, 29%. 42% had not very confident, and 23% not confident at all. Have you ever been tested or told you should be tested for an inherited thrombophilia? Yes, I've been tested, 48%, so nearly half. Yes, I've been told I should be tested, 7%. 38% said no, and 7% said I'm not sure. Final question and results. What is your biggest concern when thinking about thrombophilia testing? Finding a genetic cause, 8%. Fear of missing something important, 43%. That's on people's minds. Cost, insurance issues, 13%. Impact on family, 15%. And at 23%, not sure what it means, and a little bit of confusion. So thanks for doing that, folks. Leslie?
Thanks, Todd. I certainly understand the confusion. I know when I was diagnosed and ended up having to give so much blood for testing, they don't explain very well why they're
Mhm.
doing it and why this is necessary. And it really wasn't until I started interacting with the NBCA that I started to understand why this was necessary. So, Dana, we've got some work to do collectively, I think, to communicate better with patients. So, we always like to start with the basics. So let's in simple terms for patients, for lay people, explain what thrombophilia is. So this is gonna be a multi-part question, so I can come back to it if you forget part of it. How many are there? And can you walk us through what they are? So I think we're familiar somewhat with factor V Leiden, obviously. Todd talks a lot about that, him having factor V Leiden, the prothrombin gene, protein C, protein S, antithrombin deficiency. And then we'll go into why do you think thrombophilia testing is one of the most misunderstood and anxiety producing topics for blood clot survivors? And what should patients be thinking about or asking before they even get tested? So let's start with the basics first, and then we'll work our way down.
Okay. All right. Well, thank you for having me. It really is an honor to be with you all today. And I will third the gratitude to all the veterans on the call today. So it is truly a pleasure to be here with you all tonight. So yeah, we'll start with the basics. So thrombophilia, what does that mean in lay terms? So thrombophilia refers to a condition where the blood has an increased tendency to form blood clots, which can lead to problems called deep vein thrombosis, DVT, or pulmonary embolism. We often refer to that as PE. And this can happen because of certain inherited or genetic mutations, or it can be due to acquired issues later in life that affect how the blood clots. So, speaking on the specific types, like you mentioned, the inherited thrombophilia. So, again, that means a person was born with genetic changes that increase their risk of abnormal blood clotting. And the most common, as you mentioned, the most common is factor V Leiden. And the prevalence of that affects about 5% of white people, 2.2% of Hispanic, 1.2% of Blacks, and 0.4% of Asians. And the factor V Leiden mutation allows factor V to be resistant to inactivation. So it does promote like a pro-clotting phenotype in a patient. The second most common inherited gene mutation is the prothrombin gene mutation, and that leads to an increase in our clotting protein called prothrombin. The less common gene mutations are all mutations in our natural anticoagulation proteins. So we talk about protein C, protein S, and antithrombin. And those three actually have a higher risk thrombophilia, but are thankfully less common than the factor V Leiden and prothrombin gene mutation. And
That's interesting. Why is that?
just their phenotype is just more prothrombotic than factor V Leiden or prothrombin.
Okay.
And then there are some other less common mutations that people are doing a lot of active research in this area to try to define that better. But we typically think of those top five as the inherited thrombophilia. And then I mentioned acquired thrombophilia. So there's a lot of different
Hmm.
people can acquire risk to develop blood clot. I think one of the big things to think about is antiphospholipid syndrome. So
Hmm.
patients, providers need to be aware and be mindful that that could be potential acquired thrombophilia. And there are other situations that people can have, like comorbidities, developing cancer, certain medications, pregnancy, hormone use, immobility, surgery, hospitalization, and even just increasing age. Those are all risk factors we can acquire with time that increase our risk of developing blood clots.
Hmm. Can you have protein C and protein S at the same time, or are they independent of each other?
So they're both rare, right? I mean, technically you can, but if you have what we would call a compound heterozygous true protein C, protein S deficiency, I doubt that would be compatible with life because we know the homozygous state of both of those is not compatible with life.
Okay, so what you're mentioning are really independent
Mhm.
versions that folks can get.
Yes.
Okay. And then just in terms of the testing, why do you think that the testing is so misunderstood and it really is anxiety producing
Mhm.
for those of us that have had it?
Well, let me just go back 1 second to what
Okay.
first comment, like, can you have more than one? So it's uncommon to have protein C, protein S together. It's not compatible with like super, super duper rare, but some people can have the two most common combination. So
Yeah.
factor V Leiden and prothrombin gene mutation, or two of each. I have double factor V Leiden or double prothrombin. So we do see those, which is compatible with like people can be diagnosed with this in, adolescence, adulthood, but their risk of clot is notable compared to just having one mutation.
It's really interesting.
Mhm.
Okay.
Yeah, you do have to be mindful about our testing, which we will.
Yeah.
Yep.
Yeah.
So misunderstood and anxiety provoking. I mean, I think this is such an important PEP talk. This is a great topic because thrombophilia testing is often misunderstood and anxiety provoking for blood clot survivors because the clinical utility of this testing is limited and the results are often misinterpreted. And this can lead to a lot of worry and confusion. A lot of patients, you can even say most patients that have developed a blood clot, probably won't benefit from the outcomes of this testing. So you really have to answer the question, what are you going to do with this result? How does it change how you manage a patient, or how you counsel a patient before you embark on testing? The American Society of Hematology, I work closely with them as well. So they have guidelines out there that actually recommend against routine testing and only test individuals for thrombophilia in select scenarios. So they have this is guideline driven, but in real world, in practice, they don't follow the guidelines. And I think that's a couple different reasons. I think, you know, as clinicians, you want to provide answers, you either reassurance or an answer of why it happened. Sometimes there's perceived pressure from the patient or family of they want answers, why did this happen, which is, of course, is completely understandable and natural. But this can lead to some unnecessary testing, and then the testing is not perfect, so you get some ambiguity in the results, and then how do you interpret it? So it gets pretty messy pretty quickly, and I think that is the root of confusion and worry.
Yes. So we're going to wear you down for a little bit and then come back to this guidelines recommending people not get tested in certain instances because people can have access to testing if they want it. And
Mhm.
so let's, be realistic about the fact that you could go to something online and get tested versus going to your doctor to get tested. So we're gonna table that one and come back to it later.
Very accessible. It's accessible
Absolutely.
clinicians. It's very easy to order, and it's very easy to get access to these things. So it's there, but then you get this information, and it's
Yeah,
not.
somebody has to educate you on the information that they're giving.
Mhm.
So for patients that are thinking about getting tested or asking before they even get tested, like what should they be saying to their clinician?
Okay, I think they should have a conversation about the purpose of the test. What are the potential benefits and potential risks of testing? I think the big question is, how will the results affect my management or counseling to my family?
Mhm.
That's really important. And I think another big part of the conversation is when, like timing of testing, which I think we can get into more. But it does matter when these tests are done. Things like the two gene tests, like factor V Leiden and prothrombin gene mutation, those are actually PCR based tests looking for very specific point mutations. So those are quite accurate and are not affected by blood thinner or an acute clot episode. But the other three, protein C, protein S, antithrombin, those are all affected when someone has a fresh blood clot, meaning they go low because their body is using those up to try to enhance the anticoagulant effect. So that is not a good time to test. And blood thinners, when you're on a blood thinner, will also interfere with those functional three tests. So I think asking as a patient, when should I get these tests drawn, is an important question.
Okay. I mean, I think it would be great to come up with a list of questions for people to ask their doctors about thrombophilia testing. You use the term PCR. What does that mean?
polymerase chain reamplification, something like that. It's a test. It's an analytic test where they look for a specific gene mutation, they amplify it so they can tell you, yes, you have a specific genetic mutation.
Okay, thank you.
For the acronym.
Okay. Todd? Yep, you're on mute.
That's because I have a cold, so usually I'm not muted.
I was gonna say, I don't think you've ever been muted.
We're going to touch on this a little bit later too, I'm sure. But just to be clear, and I talked to, factor V Leiden is prevalent out there, and we have a lot of people in our group. And since I'm factor V Leiden homozygous, I talk about it a lot. But there is some confusion. But just for some clarity, to be tested for factor V Leiden, you can be on your anticoagulant, correct?
Yeah.
Okay. And we're also going to talk about this, but it comes up in the group a lot. There's a big difference between heterozygous and homozygous. Can you just touch on that just real quick?
Yes. So I kind of talked about it a little bit. Maybe I can, I'll elaborate more. So heterozygous means you've inherited one bad copy from one of your parents, and then you have one good copy from the other parent. And homozygous means you have a defective gene from both mom and both father. So having two bad copies of a gene it amplifies the mutation, and it is a higher risk of blood clot if you have a homozygous state for factor Leiden.
Right. Yeah, a lot of factor V Leiden people out there. I meet them every day, brand new, just got diagnosed with it. They do have a lot of questions, but let's talk about timing of all this.
Mm-hmm.
Why is it problematic to test certain thrombophilia markers while someone is on anticoagulation? So here's a couple of questions to throw at you. Which specific thrombophilia labs are influenced by blood thinners again, and which ones are not? I know we touched on it. How do these inaccurate or misleading results potentially change the patient experience and decision-making negatively? And when someone is already anticoagulated, what is the realistic timeline or window for accurate retesting if needed?
Oh, good question.
Okay, so I'm gonna try to remember all those. You correct me if I'm going off the topic. So as far as which ones you can test. So again, you can trust the PCR-based test, factor V Leiden, prothrombin gene mutation, but anticoagulants will affect antithrombin, protein C, protein S in kind of different ways. So if you're on anticoagulation with Coumadin or warfarin, those will decrease your protein C and protein S level universally, and like to a notable degree. So I've seen patients labeled protein C deficiency and protein S deficiency, and like I said before, it's not considered compatible with life necessarily. So you have to ask them, was this tested while you were on Coumadin? Yes, yeah, that's the case. So, and then the DOACs, so rivaroxaban, apixaban, those are kind of the most common used anticoagulants as far as, non-Coumadin oral agents. Those can actually mildly increase protein C and protein S level. You can get a false elevations. You can kind of get a false reassurance if you're getting those tested while on one of those DOACs that we call them. And then timing of testing too. So again, if someone has an acute clot or is on something like heparin, for example, your antithrombin is going to be low. Same with protein C, protein S. So you really have to wait. If you're going to test, you have to wait till the acute clot period is over. And generally, we consider that about 3 months. At least 6-8 weeks. But if you can get longer, that's better because the body's kind of reacclimated and the clotting proteins have gone back to their baseline level. And as far as how long to wait after a blood thinner is paused, and I think one is that you have to ask your provider, is it safe? Is it advisable for me to pause a blood thinner? And if the answer to that is yes, it's worth it, then how long? And so Coumadin, it's actually 2 weeks. 2 weeks stopping Coumadin before you can trust your protein C, protein S activity assays. A little shorter time with the DOACs. So we talk about a couple days off rivaroxaban or off Eliquis before you can test those functional assays.
Will they ever like rescan you, do another ultrasound, make sure the clot's gone before they decide to do the testing, just to make sure it's out of your body? How do they do that?
So So that's an individual assessment. I wouldn't say that that's, standard. There's a standard practice that's written. So I can tell you kind of in my practice, I will generally repeat ultrasound. Again, is it going to change my management, or is it based on a symptom, that we need to check this out because there's something going on, the patient's not doing well and we need to take a look. So that's not black and white to rescan. And especially what you have to think about with CT scans, that's more radiation, that's more contrast exposure. So is the test, not to mention cost, to the healthcare system, but is that test worth it? Like, what information are you really looking for?
Right. And everybody needs to have a hematologist on board, right? I mean, if you've suffered a blood clot, shouldn't a hematologist be one of the first doctors on your team, one of the first ones you meet with?
Well, I mean, I think I have a biased answer, but I think would say yes, but I don't know, thinking broadly across the US, I don't know if that's realistic for everybody. I think there's a lot of areas where they may not have, access to experts. So I think medicine has to be trained, enough to understand when to start a blood thinner, what are the pros and cons, how do you start them? They need that training, and we do get that training in internal medicine. So, but I think yes, in an ideal world, a hematologist would be involved, or a vascular medicine specialist. Some areas of the country have that sort of subspecialty.
Right. I was real fortunate to have a primary doctor that seemed to know a lot about it and was able to guide me through that process without having to see the hematologist right away. But like you said, in some areas, access to certain doctors with certain specialties, it really is hard on patients sometimes.
Or access in general, even if you're in a populated city, but the next classical hematology appointment's 4 months away, you can't wait that long.
Right.
Well, and there's fewer and fewer classical hematologists now as well, which is
Right. There is
right.
a big
Which is why it's important if you're being treated by a PCP that you have this information so that you can, talk about your own condition and ask the right questions, because coming off an anticoagulant is really scary after a blood clot. And so, understanding why and understanding the risk factors of that is it's really critical.
Absolutely. And you talked about, how does the inaccurate or misleading results change a patient experience? I think that's important too. And I think it can be root of a lot of anxiety, confusion, and mistrust. Like I said, people carry diagnoses for decades that are inaccurate. And, they've talked to their family, they've made certain decisions, and it was based off bad time tests or testing, not well explained interpretation of the tests. So I think the uncertainty around testing and counseling can cause some distrust and negatively affect the patient experience. I mean, I hear that from folks.
Yeah, for sure. I think you answered all the questions I had, Leslie.
Yeah, but this does come up a lot in the group.
It does.
And so making sure people have this information is just so critical. Okay, so we'll kind of get back into what we had addressed earlier here, but so in what situations does thrombophilia testing genuinely add value for patient management? And does testing in someone who already must be anticoagulated, like unprovoked VTE, which is what I am, typically change anything meaningful in care decisions? So we'll start with those two, and then I've got two more to add on to it.
Okay, sure. So when does thrombophilia testing add value? So, and this is in concordance with guidelines, when you have a high suspicion for thrombophilia, because oftentimes folks with inherited thrombophilia present in younger ages. Like I said, age is a risk factor from thrombosis, comorbidities that come with age. So if you have a young person, like, well, we say young, that's relative, right? But let's say 30s or 40s, like we're talking less than 40, 50 age with a clot that came out of nowhere. That kind of raises a flag. This person could have an inherited thrombophilia. And we also obviously talk about family history in our visit and, spend some time there. So paying really close attention to any first degree relatives that may have had a clot. Also, thinking about, did that family member have a clot at a young age? So we're asking who, we're asking what age, we're asking circumstances of that family member, because I want to know, was that family member's clot sounding provoked by something, or was it also unprovoked? That's something to think about. And then we really do value when clots are in odd locations. So we think about cerebral vein thrombosis or blood clots in the abdomen, splanchnic vein thrombosis, portal vein thrombosis. There are a couple disorders that can present with clots in unusual locations. And so, unveiling that can definitely lead to different treatment in diagnostic issues. So that's when we think about doing thrombophilia testing for the highest yield. And to your point, I think you mentioned and this, I ask myself this every time I think about it, how do the results change your management? Because you're going to do the same thing anyway. Why are you doing it? And I know the reasons practically. Like it's tempting. It's there. Patients want it. Patients want answers, and you want to give them that. You want to either give them, reassurance or an explanation. So it's there. But I think it is helpful when you have testing and you're going to do something with it. So, and particularly when you really have trouble answering, should this patient in front of you be on long-term blood thinner or can they come off? So that's probably where it has a lot of clinical value of will it change my management? Because if you find something, you're probably going to lean towards tipping them into a longer term blood thinner management plan because there's already an underlying risk, and then you just need one more thing kind of to tip it off typically. Whereas if it's negative and you had a weak provoking situation, you may end up saying, okay, everything's negative. You don't have any added risk. We can safely stop blood thinner. But the unprovoked clots, they do worry us because if it came out of the blue once, so it can definitely come out of the blue again, regardless of your thrombophilic status.
Yeah, no, it's a very good point. You touched on, we refer to them as higher value situations. So you
Mhm.
mentioned the young patients, unusual clot locations, and then strong genetic family patterns. Is there anything else that you would consider to be kind of what we refer to as the higher value situation?
Well, did you mention the unusual location? Because
Yeah.
for things like myeloproliferative neoplasms, like polycythemia vera, essential thrombocythemia. We're looking for a rare disorder called PNH, paroxysmal nocturnal hemoglobinuria, which have specific, that's a specific diagnosis with specific treatment implications. So that's another high yield testing.
Okay. And then, I mean, you kind of touched upon this already, but so when is repeat testing reasonable versus unnecessary? Um,
Right. And I am faced with that. So, okay. So the short answer is, what are you going to do with it? But the long answer is, there's a lot of ambiguity, especially with those functional tests. And to be honest, I had one today come up in clinic. So, protein C, it's a little bit low. Is that real? Is it just a little bit low? Could you really have a heterozygous mutation in protein C, or is it just you kind of have a little bit of a low level below? So you have to think about what's going on and with the patient when the testing was done. And so repeat testing can give a little clarity. Was it just a fluke? Was it just down for XYZ reason? And then here's your real baseline. So that can provide some value as far as repeat testing. When it comes to that antiphospholipid syndrome, that by definition does require repeat testing to meet criteria for that diagnosis. So I know it's a little bit off topic. It's not inherited thrombophilia, but repeat testing for that is, I think, worth mentioning to the group.
okay. So it's fair to say that not all testing is equal, not all timing is equal, but can you help patients understand when to advocate to not be tested unnecessarily?
Mm-hmm. Sure. I think this is important. I think this, reasons for this pep talk is so valuable to empower everybody to know what questions to ask, what to look for. So I think if the role was reversed, what I would want to ask was how likely will this testing explain why I had a clot? I think that's a lot of what I'm hearing from patients, which is again completely makes sense, completely natural. Is why did this happen? So what are the odds your testing is going to tell me that answer? Because
Mhm.
that's talked about in the
Yeah.
clinic for this testing is just, we can get into the numbers in a little bit, but it's not as high as we all would want. I mean, up, at least 50%, I would say, of time. The literature's a little bit all over the place, but at least 50%, we can't explain it with our testing. So I think being upfront about that is helpful. Another question I think is, how will results impact my family? I have a daughter. What
Yeah,
about
great point.
birth control pills? Or, my son needs to have a hip surgery, like obvious things of this kind of risk. And then how will results impact my management? Will I be able to come off a blood thinner if it's negative, or will I stay on a blood thinner if it's positive? Or are you going to do the same thing regardless of what the test shows?
Mhm,
So I
okay.
think big three, I think.
Yep. So to test or not to test, that is the question that I ask of thee, which you have nicely answered. Todd?
Yeah, the whole I just go back to the anxiety thing because you hear so much anxiety coming out of patients, and you were talking about PV, and I just wanted to mention recently I just had to be tested for the JAK2 mutation and had to check my EPO levels because my doctor's so thorough about investigating. So,
Mhm.
I try to
You're
practice
lucky.
what I preach and handle anxiety and show people how to do that. But even I suffer anxiety, and for a couple of days there, I was like, man, what if I have to deal with something else? But that was
Right.
the only second time I've ever heard PV mentioned was when you just talked about it. I didn't know a lot about that, but
Yeah.
um, this is a really good segue what we were talking about before going into the family side, because we get this
Mhm.
a lot in the group too. But when there's family history, when is it truly appropriate to test other family members? What is the role of genetic counseling in interpreting results that may have lifelong implications? And do you think knowing a thrombophilia status creates an emotional coping benefit, or does it sometimes worsen that anxiety and
Mhm.
the fear identity?
Okay. So again, there are some guidance on this. Again, I'll quote American Society of Hematology on this, that in individuals that have a family history of a high risk thrombophilia, so again, that's the antithrombin, protein C, protein S, it is recommended to test family members if they are also going to be exposed to a moderate risk factor for clot, like kind of a minor surgery or, brief hospitalization, something like that, um, to see if that family member warrants prophylaxis against developing their first blood clot, if that makes
Mhm. Yeah.
so higher risk. But the lower risk thrombophilias, factor V Leiden and prothrombin, the guidelines suggest to not test family members. Even in the era of thinking about birth control pills, estrogen, hormones, that, having factor V Leiden heterozygous is not a strict contraindication to starting an estrogen. I mean, it's a conversation if someone knows their status, but it's not, black and white. You cannot be on hormone with that status. So again, it's the higher risk thrombophilias. First degree family members can be tested if they're going to have some increased VTE risk situation in front of them.
Mhm.
And I don't remember the second.
Well, I was, do you think knowing a thrombophilia status creates an emotional coping benefit?
I think it's individualized. I can imagine. I I think I've seen the spectrum from my patients. Some are quite neutral emotional response to knowing their status. Some, they have relief, either knowing why it happened or knowing their testing came back negative. And then the opposite's also true. I think it can lead to heightened anxiety and worry about pains, twinges. Is my leg, this one, just a millimeter more swollen than the other one? I think it can really affect people, and it's hard because
Mhm.
you don't want to overanalyze, but you also want to ignore, how serious it is. So I really have seen the spectrum of response.
Yeah, what about testing the kids? I mean, are there age limits? Is there age groups that should be tested?
Yeah,
Should you hold off?
just to test children. Again, you're not going to do anything with that result to them as a child. I mean, out
Right.
extreme circumstance, and so I do not think it's worth having
Okay.
a child go through a blood draw for that kind of test. So it's more like adolescents and older if they're going to be exposed to some other VTE risk, that it's worth knowing. But it's, yeah,
Yeah,
quite
that's a great point. A lot of people ask about that, so that's a
right.
really good point.
Oh,
You
yeah, I get that
explained it
question.
very well.
Yeah, and then they're relieved when you say, no, you don't have to test your young child. They're like, okay, good.
Right, right.
But let's say you have a young girl and she gets to
Mhm,
an age where she might be on hormonal birth control. You obviously
mhm.
want to have that conversation just to be on the same.
Right, if it's the higher risk
Yeah,
thrombophilia. Yeah.
exactly. Can you guys just come back to the genetic counseling? I know, Todd, you've got some experience in this as well, but um, what is the role of them? How do you use them, and how does somebody find one?
Yeah, that's a good question. So again, I don't think it's available all over, right? So I think certain areas have access to genetic counselors. And so I think they can be helpful. I do think if you're in the hands of a hematology specialist that, or like I said, primary care that has good understanding of this, they should be able to counsel you through it. But if you have access to genetic counseling and want extra detailed discussion on limitations of testing, kind of knowing which ones can have false positive results, and also just the general counseling that just because you have a positive status doesn't predict you're going to have a VTE recurrence. So they can talk about potential clinical management, talk about reproductive issues, how are these genes passed through our genome down to offspring, and then maybe even talk about preventative strategies for high risk situations. So I think they're a wonderful
Mhm.
adjunct to physicians, and I think they can add value.
Okay. Two things. One is we do have on the website, and Taryn is behind the scenes with us tonight, information about genetic testing and the counselors that are involved in that. And I think there's a link if people are interested. And then the other thing that I would like to encourage people to do is really take the time to learn about the guidelines, because the guidelines are what you folks use to drive a lot of the decision making that it happens in terms of how we get treated as patients. And it doesn't mean that, your hand is held to the fire all the time.
Mhm,
You make decisions based upon, information that might not be available in the guidelines. But the guidelines are important. And really, it's a great opportunity to have more control, more understanding, better educated conversation with your doctor if you read the guidelines. Um,
mhm.
and so, I encourage everybody to do that. I know Taryn dropped in the chat function here, American Society of Hematology. You've mentioned that a couple times, the guidelines that are available. So it's free, it's accessible. Use it. If you have a question, reach out to us. We'll be happy to share information about what some of these things mean. So knowledge is power. The more you have, the better it is.
Absolutely.
Great.
And the other guideline is often referenced are the chest guidelines.
Yeah, good point. Okay, so we will drop those in also. Okay, so we're going to do a little kind of a fun thing, I guess, here. We have a new topic for you called Dana gets to discuss misinformation, myths, and noise, because there's a lot of that. And again, we've got a bunch of questions for you. So the first one, and maybe Todd, I'll take half and you take half if you like.
Sure.
First would be, what is the biggest myth in thrombophilia testing that you want to correct today?
So I think the biggest myth is that thrombophilia testing will explain to me why I had my blood clot. I think, and I mentioned the numbers, and it's a little variable, but at least 50% of the time we cannot find a hereditary thrombophilia for a patient with an unexplained blood clot. So I think going into discussions with physicians, it's just having that framework so you're not, set up for disappointment when you don't get that clear answer that you may be looking for.
Mhm.
Okay. Um, what should patients look for to assess if information they see online is credible versus misleading? And this gets into what we were talking about before. You might want to get tested for thrombophilia, and your doctor says, well, you don't need to because it's not going to change the way that I treat you, which is really, it's hard for patients
I
to,
know.
it's really hard. Like I can't stand when they say that to me, but I understand why they say it to me, because you want a response and answers to why something happened. But I
Yes.
can also go online and use one of these services and get information and not have a hematologist like you tell me what it is. So, um, what should they look for to see if the information online is credible versus misleading?
Mhm.
Well, yeah, so credible articles, I mean, you'll have like an identifiable author, their qualifications, institution they work with. There are reputable government websites, academic websites, medical organizations, a couple which you just mentioned, like CHEST or American Society of Hematology. And I would also pay attention to dates. So the field is rapidly changing. So there is a lot of papers out there that get outdated and updated. Like, let's take, for example, that MTHFR gene mutation. So decades ago, there was thought that that was a clot risk factor, and now updated information suggests it's not really a genetic factor that increases risk of thrombosis. But we still, to this day in 2025, get questions and referrals for that specific gene mutation. So sure, you can find a paper on it, but it has since been debunked. And so kind of looking at updated information from reputable sources is important.
Okay. And we also don't know what they're doing with the information.
What do you mean by they? The,
Anybody that's online, that's,
oh,
at least if I go to Danny Angelini, I know where my information is going versus being sold someplace
oh,
and
sure.
just
Right.
making sure that everything is safe.
Oh, of course. Yeah. If you're putting your own things in some box, yes, that is worrisome.
Yes. Okay.
Well,
Yeah.
yeah, and Leslie knows we deal with that. I have to keep an eye on in the group because somebody may want to do a poll or something like that. And you never know who's
Yeah.
doing that and where they're going to give that information to. A lot of times
Yeah.
it's innocence, but that's why we don't allow polls in our group because it's got to come from us. We just can't have somebody making up polls. But excellent point you made about looking at the dates, all of these articles, all the ones that look like they have a lot of really good information that are signed by all these well-known authors. There are dates there, and I've seen some people trying to post articles with dates being 2007, 2008. It's like there's been a lot of changes
Right.
since way back then. So always look for that updated.
Mhm.
Um, so we're going to touch on it again, but if a patient is already on long-term anticoagulation, when is testing actually not needed?
Well, yeah, if you've already committed your patient to long-term blood thinner, again, are you going to change your mind? Now, there are some nuances to long-term blood thinner. Can you reduce dose, especially with the DOACs? There's data on reduced dose DOAC for long-term VTE prevention. Does that apply to someone with homozygous factor V Leiden, for example?
Mhm.
And say, no, that's been specifically studied. But I think there are some nuances to that. But generally stating, if someone is already committed to a long-term blood thinner plan, and especially if they've been doing well on it, if there isn't any concern for breakthrough thrombosis that's unusual,
Right.
um,
Mhm.
I would say it's not going to be helpful in that situation.
Yeah, that's logical. I agree with that. So think of some questions. What are three practical patient questions that they can ask their provider before agreeing to thrombophilia testing?
So I think some questions would be, do I, as a patient, do I have clinical features? There's something about my presentation with clot trigger you to think about hereditary thrombophilia? So we'd be going back to young, um, or unusual location, or strong family degree. I'm sorry, strong first degree family members. So do I have a high likelihood of inherited thrombophilia? And then we've been harping on it. Will the results change my management for me or my family? And are there potential risks or costs? We really didn't talk about cost of this testing, or any insurance complications. If this goes on your medical record, are there issues with getting insured? So people bring, these are important things I think to think about before embarking on it. And then the other issue is this a good time to test? Is a good question
Mhm.
to ask. And I,
Do you ever hear someone ask, can't I just do this testing? Can I just do the 23andMe thing?
so
How
yeah,
accurate is that? Is that even a wise idea?
so clinically we will always do our standard testing, even if someone brings a 23andMe copy of a gene abnormality. It's not that I would take that and put it in the medical chart and go with that diagnosis. So we will always confirm it, at least in my practice, what I see people doing. So I don't refer people to do 23andMe testing. I think that's kind of
Right.
commercial and maybe of personal interest, but I think it's to bring to the physician, talk about it, and the physician will have to clarify what's.
Yeah. Good answer.
Yeah, no, that's what we were just talking about. All right. So if you don't mind, I'd like to open it up for questions now because we have a ton of them. And this is always the fun part of the evening, Dana, where we get to put you on the spot a
Oh,
little bit.
sure. I just
And
one more point about because it popped in my head and then we had to move on. So do you have access to PubMed? That's that public? I think it is, isn't it?
yes, it is public.
Okay,
Mhm.
so PubMed is a good place to get verified sources. So I would just say reputable journals are indexed there. So if you need to find articles, that's a good place to navigate to. So had to throw that in there.
No,
Yeah, that is a good one. A lot of good info there.
yeah, no, it is. And we really do want people to learn about the guidelines and how it influences decisions that are being made about your health situation. You made the comment about, and this is for pulmonary embolism, about not getting, tested too often because you don't want to have too much radioactive material floating through your body with the scans. So, you can learn about stuff like that in the guidelines.
Mhm.
Okay, so somebody asked the question about MTHFR, which we did not talk about tonight. Thoughts on that?
Right. So I did make a little comment on it because I thought it might come up. And again, this was sort of, you know, decades ago thought to be a gene mutation associated with increased VTE, but newer data suggests it's not. And there are now advocates to take out MTHFR gene testing from thrombophilia panels because a lot of times it is just that. It's a panel you can click and you can get all of them at once. But it's not widely adapted yet. So there are some like maybe smaller community hospitals that still have that panel and it's in there. So we still get questions about MTHFR mutation. But this day and age, we do not consider MTHFR a genetic risk factor for clot.
Okay.
Someone asked me what MTHFR stands for. Please don't do that. Because I'd have to look it up. Is it May Thurner? No, it is not May
No.
Thurner.
No, it's not May Thurner. Yeah.
There's a different, May Thurner is an anatomic predisposition to developing blood clots. So MTHFR, okay, I'm going to try it. Methyl tetrahydrofolate reductase mutation. Don't quote.
Sounds good.
Yes, I got it. Methylene tetrahydrofolate. I was right.
There you go. Of course you are.
Yeah. Yes.
Okay. I'm gonna take two. We're gonna do it a little different tonight. I'm gonna take two. You're gonna take two, Todd.
Okay.
We'll break it up that way.
Yeah.
If you are on APS, or if you have APS, excuse me, can you be on a DOAC or not?
Oh, goodness, that's a big question, Leslie. Well, we know that the high risk APS profiles, we call that triple positive antiphospholipid. So that means you have beta 2 glycoprotein positivity, anticardiolipin, and the lupus anticoagulant, all three, especially those of high titer. Of all of those, we prefer Coumadin, and that's been studied in randomized controlled trials that Coumadin outperformed the DOACs, Xarelto and Eliquis. So that we all agree Coumadin is preferred agent. The lower risk APS profiles, jury's still out. We're trying to study that better collectively. And you mentioned CERT. So part of this emerging researchers in thrombosis. So we're planning a multi-center to pool our data together to look at outcomes of APS patients with lower risk antibody profiles and seeing those who have been on DOAC, who've decided or have navigated or have been on DOAC and have been doing fine, their joint decision making is to stay on it. How do they fare? What are their risks of recurrent blood clot? So we're trying to get more data. So that is still very much an individualized discussion between a patient and the physician if they don't have that triple positive high risk APS profile.
Great. So we'll keep everybody abreast of what that project
Yes.
is.
Need more data on that.
Yeah, for sure. That's a great one. Todd?
Yeah, let's just keep them coming out of the Q&A box here because we've got quite a few. Can you have factor V Leiden and protein C deficiency together?
Yes, I would. Yes, I have not personally run across a patient with that combination. I'm trying to think. No, but it can happen. Yes, I would say yes, that can happen.
Okay.
Can I make one quick comment on that? So
Mm,
protein S deficiency with factor V Leiden, you have to be a little careful about the diagnosis of those two together because the factor V Leiden will affect the testing of protein S. So be wary if you get told
Ah,
both
Interesting.
S and factor V Leiden. But
that's-
for whatever analytic reasons of the testing, it doesn't affect protein C the same way.
wow,
Okay.
that's really interesting.
Mhm.
Yeah, it is. It
Yeah.
is. And I know we touched on this. Let's go ahead and just ask the question as it's presented here. So if you've had your testing done while you're on your DOAC, does it all need to be redone?
Not necessarily. There's a mild increase in protein C, protein S. I don't believe it increases antithrombin, but there's a mild increase in that. So again, it's maybe up as much. I would say maybe up to 15% increase. So if you have a true protein C or protein S deficiency, you're usually in like the 50% functional percentage range. So even if you're on a DOAC, it's not going to bump you into normal range. So again, it's interpret with knowledge, not an absolute must retest, but it is ideal to get the testing off blood thinner altogether and far away from the clot event. You can trust it the most.
And the provider that's doing the testing, I mean, they're going to fill you in on this anyway, but these are good questions for them to ask their doctor
Yeah,
just to get that clarity.
love every provider to know this and to share, but I don't, to be honest, know if this is all the nuances are widespread knowledge
Yeah.
throughout all medicine
Yeah.
providers.
Okay. Thank you, Leslie.
Oh, there's some amazing questions here. So, this one, wow. Okay. I
Mm,
was tested twice for factor V. One
okay.
result said homozygous, one result said heterozygous. Just
Oh,
wondering if there was a reason this can happen or was one test possibly wrong?
so no test is perfect. So I mentioned they're very accurate, the factor V line and prothrombin, but they're not perfect. So, but we're talking accuracy is around the 98 percentile. So it's really, really good. So that's interesting. Honestly, I would, in that situation, I mean, this is obviously cost aside, but like I would do a tiebreaker because I think that would matter. You know, the homozygous state versus heterozygote. Again, if it's going to change management, but I think that does. I would want to know as a physician, and I know as a patient, you would want to know which one is it. This is a big kind of a big difference.
Absolutely.
I would
So,
say a tiebreaker retest with the PCR.
okay, so the patient should go back and say, hey, retest. And if the clinician says, no, find a new clinician.
Yes, I think so. I think so. I mean,
Okay, it's okay.
unless like I'm not treating you different, we're not gonna, like again, that's a very big difference. So
Yeah.
if I would what?
No, I think you're spot on. Tiebreaker, get another test.
Yeah,
Okay, another great question here. At what
that's
age,
a full situation though, but that's yeah, okay.
at what age would you expect a patient is of age where they had a VT incidence unprovoked, but they are too advanced in age to have an unknown clotting disorder? It's like a trick question.
Okay, I'm trying to. Okay, so I was saying like maybe someone in their older, like in their 70s, 80s, had an unprovoked clot, but maybe they had a hereditary thing this whole time. Is that what I'm hearing?
That's how I'm
Yeah. Well,
interpreting.
okay.
At what age would you expect a patient is of age where they had a VT incidence unprovoked, but they are too advanced in age to have an unknown clotting disorder? Kind of like Todd, like if he was having all these clots, but he's, 60, sorry, Todd, 2, 1.
So
Um,
there's probably added VTE risks going on. So again, age being one thing, comorbidity. So it's sort of like a pot. of risk factors. And then if you get the right combination and the right recipe, then the clot can develop. So with advancing age, sir, someone could have factor V and never know it, but lo and behold, they are in the hospital with a pneumonia, they're dehydrated, and then there's that recipe for the blood clot. So they may have had it the whole time, but not clinically significant by itself. But when you add it to other things, it makes things more risky. But the only age cutoff that's out there is the less than 40, 50. And there's like that range, right? So is it less than 40s or less than 50? I'm 45. Like, where do I fall in that? But the younger folks is where, the testing is thought to be more high yield. So, over 50, it's probably not high yield to test. So I don't know if I'm answering the question, but.
Well, I'll tell you what, all I know is I had never suffered. Now, my mom died of pulmonary embolism. She was 43. And that was back in 84. That was before factor V Leiden was discovered. There was no talk about it. You think awareness is struggling to get out there now. Think about back then, right? But I keep thinking I didn't suffer a clot until I was 48, and it was because of a really severe leg injury there was a lot of bleeding. I keep thinking if that never happened, I wonder what my odds would have been that I may have never suffered a blood clot, because it seemed to like almost flip a switch, right? In my mind, it was like, then I just wanted to keep clotting after that. But
Okay.
yeah, but anyway, so forget about me. Get back to the questions. Can you comment on how long after stopping Lovenox injections can you test?
Okay, that's a good question. So you always have to think about half-life of these drugs. So half-life of Lovenox means, how long is it in your system before half of the drug is removed. So you do need several half-lives before all the drug is gone. And a little bit depends on kidney function too, because the kidneys help remove Lovenox. So in someone with normal kidneys, and on a standard dose of Lovenox, you only have to wait, like 1 or 2 days, and then it should be mostly out of your system to test.
Okay. All right. And so someone is currently on Eliquis and Plavix.
Okay.
What would the process be, since they would be like to be taken off thinners? You have to go between vascular and hematology. Since they both prescribe a different thinner, who is it that you want to talk to?
Sure, that's a lot. There's a lot of people that prescribe antiplatelets, neurology, cardiology. They're not as accessible as hematology. No, I'm just kidding. But no, I'm just joking. But so Plavix is an antiplatelet that does not affect blood clotting assays. So I don't make people come off Plavix to test.
Okay.
Yeah.
And that's just like low dose aspirin, right?
It's similar, yeah, antiplatelet.
Very similar.
Yeah, but it doesn't affect clotting.
Okay. All right. Leslie, you're up.
This is another great question. Could my factor V Leiden caused 3 postpartum hemorrhages and 3 pregnancies?
So we don't consider heterozygous factor V Leiden to be a bleeding risk. So postpartum hemorrhage is bleeding. So no, I do not think that would be related.
Okay. First PE was idiopathic. Second PE, 12 years later, there was talk of stress-induced lupus, but still nothing concrete. What should be done to get further information on this? No protein S or C or antithrombin 3. Wow, that's
So
quite
some
interesting.
had one unprovoked and one maybe provoked due to illness. So I'd want to know about the antiphospholipid test, especially when you talk about lupus, because there's overlap between lupus and antiphospholipid syndrome. So I think that would be important to dig into that. But like I said, it may be one of these situations where we have an unprovoked or weakly provoked clot and we can't find a genetic cause to it.
Okay. All right. I am cognizant of the time. You have very graciously afforded us a lot of time this evening. This is a fascinating topic.
It
I
is.
feel like we could do this 20 times this, over the next 6 months, and I still wouldn't understand everything. But thank you for making yourself available to us. Todd, I'm going to turn it back to you. I know we have some post questions that we want to give to folks.
Yep, we'll read off. I'll read off the post poll questions as soon as they pop off the screen, just like at the beginning, of folks. Just I'm going to read them to you, make it a little easier for you. Read along, answer them, and I'll give you the results. After today's session, how confident are you in understanding when thrombophilia testing is appropriate? very confident, somewhat confident, not very confident, I'm not confident at all. Our second question, do you know, or do you now understand why testing while on blood thinners can lead to inaccurate results? We talked a lot about this. Yes, very clearly. Yes, somewhat, not really. No, still unsure. And the final question, after this discussion, how likely are you to ask your healthcare provider how any lab test will change your treatment before agreeing to it? Very likely, somewhat likely, not sure, unlikely. When the results pop up, I'll give those to you. Let you know what those answers were. This is a great way for us to see what people are thinking before and after our pep talks. And they always seem to make such a great difference, Leslie. I mean,
Oh,
even tonight, all the stuff that we learn when we think we've known a lot already,
yeah, I
there's
agree
always
with you.
something else. And you said knowledge is power, and that's one of those are beautiful 3 words. Knowledge is power for sure.
I do find this very confusing though.
Yep. So here we go, folks. The answers to those questions after today's session. How confident are you in understanding when thrombophilia testing is appropriate? 31% said very confident, somewhat confident, 57%, not very confident, 12%, and 0% good for not confident at all. So we learned something. Do you know now understand why testing while on blood thinners can lead to inaccurate results? 44% said yes, 51% said not really, and 3% or 51% said yes, somewhat, 3% said not really, 3% no, still unsure. After this discussion, how likely are you to ask your healthcare provider how any lab test will change your treatment before agreeing to it? 47% said very likely, 39% somewhat unlikely or likely, 5% not sure, and 8% unlikely. So thanks, folks, for answering those questions.
I have a suggestion for folks that are on the call. Send us your questions that you feel like were not answered, and we will do a mini PEP that will be pre-recorded where we answer these questions so that there's a recording of this so people can help, they can make the decisions that they need to make for themselves. Because I agree, it's a very complicated, and sometimes it's not a yes, and sometimes it's not a no. And sometimes the patient has a different objective than the clinician does. And I think that's part of what makes this whole space complicated.
And I think that's a great idea about the mini PEPs, because that's the mini PEPs that we have. They're short, they're fast, and
Yep.
they answer those questions that maybe
And
couldn't get answered.
people can refer to them.
Yes.
Dana, thank you so much for your
Yes,
time.
thank you.
Great to have you here. Todd, as always, thank you for doing such a wonderful job as a co-host. And we'll see everybody, well, maybe not everybody, but next month is new patients. It's a boom, boom, boom. Come ask your questions, learn about blood clots, and we'll see you the second Tuesday of December. Good night, everybody.